in a 12-step program and you don't look at or rehabilitate his brain, it's not going to work nearly as effectively as if at the same time you're teaching him how to modify his behavior, you're also optimizing his brain. The next part of the brain is just so interesting. And I have to tell you, I learned not one thing about this in my residency. And I'm a double board certified psychiatrist. I'm board certified in general psychiatry and child and adolescent psychiatry. They didn't talk about the cingulate gyrus at all. But when we started doing imaging, and there's a whole imaging literature on the cingulate gyrus. Think of the cingulate gyrus in three parts. There's the posterior cingulate gyrus, so that's here, back toward the back. The middle cingulate, which is here. And then the anterior cingulate. Anterior just means toward the front. The cingulate gyrus runs right on top of the corpus callosum, so that's part of the cortex, right on top of the corpus callosum, or that big white matter fundal fiber that goes between the hemispheres. The middle cingulate is more involved with feeling your body, especially pain sensations. The anterior cingulate, so toward the front, has the dorsal part on the top. That's involved in thought shifting. And the ventral part, so think of it underneath between your eyes, is involved in emotional shifting. There's actually been research studies that if your ventral cingulate is overactive, it predicts a positive response to an SSRI. It's the work of Helen Mayberg. If it's underactive, it actually predicts a negative response to an SSRI. So I think of the cingulate, especially the anterior cingulate, as the brain's gear shifter. And this was work published by Alan Mirsky when he was at NIH. The anterior cingulate is your gear shifter. It's involved in cognitive flexibility, shifting your attention, going from idea to idea, from thought to thought, seeing your options, going with the flow. It's involved in cooperation, getting outside of your head and into the head of other people. And one really interesting research finding is the cingulate gyrus is involved in error detection. So it tells you when something's wrong. So if I come into the studio and something's out of place, my cingulate gyrus is going, something's out of place. But if it works too hard, you begin to notice errors in other people, in your family, in yourself, and it can be the seed of a lot of trouble. When the cingulate works too hard, usually due to low serotonin levels, the cingulate gyrus is highly innervated with serotonergic neurons. So when serotonin levels go low, cingulate gyrus gets active and people get stuck and worried and rigid. And if things don't go their way, they get upset. They can be obsessive, compulsive, certain types of addictions, not all of them. But what I've seen, they also can be argumentative and oppositional. No matter what it is you say to them, they're arguing with you. In fact, they start arguing with you before you've even gotten the sentence out. And so you see it with patients. It's like, well, I think maybe we should try this. No, I don't want to do that. That won't work. I've already done that. I mean, it's like an automatic, almost reflexive response. And they see too many errors in themselves or in other people. It's like they have a little mouse in their head, and the mouse is on the exercise wheel, and the mouse just can't get off. Same thought, over and over and over. It's one of the classic early imaging findings with OCD, but not all OCD people have it. The OCD people, obsessive compulsive disorder people who have it, tend to respond to the serotonin interventions. So, an interesting question. Why does this 17-year-old who has oppositional defiant disorder drink alcohol? Well, one would suggest a calmer brain. Her brain works way too hard. This is a pattern we call the ring of fire. But running right down the middle, sort of like a mohawk, is her cingulate gyrus is just working way too hard. So she drinks as a way to put out the fire in her brain, but because she can't stop thinking about it, and to oppose her parents. So imaging adds very interesting psychodynamic information for our patients. Imaging never diminishes the need for good psychotherapy or good psychodynamic formulation. And so here we have two depressed patients. One of them with no overactivity in the cingulate, the other with high activity in the cingulate. So here we're looking up from the bottom. The top is the front, the bottom is the back. Both of them, you can see lots of red in their cerebellum in the back, bottom part of the brain. One has high limbic activity, but no cingulate. They'll do better with Wellbutrin or the supplement SAMe. The high cingulate people tend to do better with SSRIs or the serotonin supplement alternative, 5-HTP. This is a fascinating case. So this is the first time you've seen a blue, red, and white one. So blue is average activity, red is the top 15%, white is the top 8%. So white are the super hot spots in the brain. And this is an 18-year-old patient who was overweight, who was angry, aggressive, and had to smoke pot every night in order to sleep. And he didn't want to be at the clinic, but he got scanned, and what we saw is cingulate just worked so hard. It's like it's almost seizure hot or active. And as I explained, the little mouse in his head that would go over and over, I say, oh, you get your mouse stoned at night so you can shut him up so you can go to sleep. So I wrote a blog about it called The Stone Mouse Story. And these of who uses which drugs. So if you have somebody like this, they're not likely to use cocaine and methamphetamine or caffeine. They're more likely to use things like alcohol or marijuana that settle brain activity. So in the Cingulate Gyrus works two lows, published research on this, low motivation, they don't talk and they don't move. And usually it's low either because they have a tumor in the area or cyst or they've had a traumatic brain injury. When it works too high, people tend to get stuck. And isn't it interesting, there's so many different psychiatric disorders where people get stuck on things. Certain anxiety disorders, post-traumatic stress disorder, obsessive compulsive spectrum disorders, some eating disorders like anorexia early on, addictions, and people who tend to be oppositional and argumentative. So how do you help them? You raise serotonin. Now, behaviorally, distraction helps. If you get a thought in your head more than 3 times, get up physically and go do something different. You want to give these people options. Never tell them what to do, because as soon as you tell them what to do, they'll want to do the opposite. Exercise helps. Diet helps, but not high protein. High protein is not good for them. DHA fish oil, so not EPA. DHA tends to be more sedating. EPA tends to be more stimulating. And then you can boost serotonin with medications or supplements. And if they're psychotic, we'll use Risperdal or Zyprexa because they tend to have a calming effect on the frontal lobes. So the medications, I think of Prozac and her 6 sisters, Zoloft, Lexapro, Celexa, Paxil, Luvox. And the first one of all of them was Anafranil. But I like supplements for this because they have fewer side effects, especially they tend not to have the sexual side effects. 5-HTP, inositol, and the spice saffron. So there's actually about 12 studies now with saffron, comparing it head-to-head with Prozac, Zoloft, and imipramine, showing it's helpful for depression, also shown to be helpful for PMS, and was shown to enhance memory. There's also the supplements tryptophan and St. John's wort. We'll talk more about St. John's wort. It's a little trickier to use because it induces liver enzymes and can actually decrease some medications, the effectiveness of some medications.